Hi guys, welcome back. The next topic on the agenda is comparison of hepatitis C versus D manifestations, and then I'll teach you the treatment part of fulminant hepatic failure. Let's go stepwise. I'll first explain to you aspects related to hepatitis C. Please remember the fact that overall this is the number one cause why a person would be having a development of end stage liver disease. And in fact, things are going so bad that this person will also be requiring a orthoptic liver transplantation. Like in other subjects they teach you, it is the number one cause of chronic hepatitis. Yes, I agree to that. But the questions that would be asked in internal medicine will usually not use the word chronic hepatitis. They might actually ask you the number one cause for orthoptic liver transplantation. When I specifically speak about orthoptic liver transplantation, a lot of young guys like you might send me a message saying that doctor, isn't alcoholic cirrhosis the number one cause for orthoptic liver transplantation? Yes, it is one of the important causes, but not the number one. I can just put it like this, that if an alcoholic patient who's having a decompensated cirrhosis is being given a liver transplantation, that's going to be a boon to him. Obviously, he's going to enjoy it because once he gets a new liver, he might go back to his drinking ways. He might ruin that new liver that you have given him, so it's a waste of resources. So actually in alcoholic cirrhosis, you need a documentation of abstinence for as long as 1 year from alcohol from a psychiatrist before you can consider that person on the waiting list for orthoptic liver transplantation. So the message is, overall in the world, the number one cause for OLT is the topic that we are studying, hepatitis C induced cirrhosis. Now, from your microbiology classes, you are familiar with the fact that this virus is a positive sense single-stranded RNA virus, and it can cause substantial amount of damage in the liver with even normal liver enzymes. In fact, all through the discussion of hepatitis C, you will notice me saying SGPT of the patient is normal or slightly elevated. And please appreciate that in all other viral hepatitis, SGPT might be 5 times, 10 times or normal. But in this condition, this is like a slow simmering fire. It's going to fry out the liver, it's going to destroy the liver, but it's going to be gradually, I'll put it like this, fire is burning in the liver, but it is not visible. In all other cases, acute hepatitis is one of the primary presentations, but this is mainly going to present in form of chronic hepatitis. The leading route of transmission for this particular virus is not to be answered as blood transfusion. Please appreciate the fact that what is the number one cause of transfusion associated hepatitis versus how does hepatitis C spread? Both do not mean the same. I've highlighted this in even the lecture of hepatitis B, that the number one cause of transfusion associated hepatitis is hepatitis B virus. But when it comes to the number one cause of transmission of hepatitis C, in let me say 1980s or 1990s, the number one cause was blood transfusion, but now your answer will mainly be given as parenteral. You see why that is so is because nowadays the testing in the blood bank has become more aggressive, and even people have become more aware. I mean, you go to any place, if blood is being given to somebody, the relatives are always asking that is the blood properly tested or not. So because the awareness part is there, a blood bank will never try to do any hanky-panky business. They'll try to do proper testing to rule out the common infections, and hepatitis C is one of them. So nowadays it is IV drug usage and parenteral route of transmission which is to be answered first, followed by blood transfusion. Earlier times, let me say 1980s, 90s, which would be 40 years earlier, that is when blood transfusion was the number one route of transmission of this infection. Per se, I want to tell you that even if a person does develop, you don't need to note it down, just listen to my words, this statement. If a person develops acute hepatitis C infection, in majority of cases, there is no symptoms. In majority of cases, there might be only subclinical manifestation, or in fact, sometimes they can be extrahepatic manifestations. So the disease is silent. Though it's causing liver damage, it might be silent initially. Therefore, from the clinical features perspective, if they ask you that what is the usual presentation of hepatitis C, then don't answer jaundice or ascites or asterixis or the standard features of decompensated liver disease. In fact, not even jaundice is to be answered here. Mostly in the initial presentation of these patients, you would be having symptoms which could be similar to any viral illness. Most patients will be having muscle pain, will be having joint pain, so myalgia and arthralgia, which may be associated. I mean, when he comes to you the first time, no, it might look like very non-specific complaints like paresthesias. They might be itching. Now, I'm not talking about intractable pruritus that is seen in obstructive jaundice, but yes, pruritus is one of the manifestations, and additional one sometimes can be dry eyes and dry mouth. So even Sika syndrome like manifestations can be present in this condition. I basically want to teach you the fact that in a multiple choice question, if he says what is the usual presentation of hepatitis C, your answer will be it is mainly extrahepatic manifestations that will occur. I repeat the fact once again, it is not jaundice, it is not right upper quadrant pain or ascites or portal hypertension, which is the presentation. It's mainly extrahepatic manifestations that will occur. At this junction, I would also like to mention an additional MCQ which is taught even in pathology, because there are certain important, now I'm writing certain more important extrahepatic manifestations of this particular disease. Please remember the presentation is mostly like any viral illness, but certain important extrahepatic manifestations which examiners love to ask is like MPGN. You see, MGN, membranous glomerulopathy, is associated with hepatitis B, but MPGN is associated with hepatitis C virus. So is the associations like lichen planus. So these are terms which I definitely want you to remember. MPGN, lichen planus. Then is porphyria cutanea tarda. Yes, the same disease in which you study regarding the photosensitivity component. So photosensitivity is not only necessarily, but we read about this also in disease where there is a defective heme synthesis. One of the common types of porphyria is porphyria cutanea tarda. The next term is also something that our examiners love to ask, that is mixed cryoglobulinemia. So I definitely want you to remember two domains here. Let me just repeat them for your convenience so that you can understand the right perspective. If the question simply says what is the commonest presentation of Hep C, your answer is extrahepatic manifestations, which are written in blue are the standard ones. But over and above this, especially pathology people would love to ask you regarding the information that I have mentioned in red. You see, had I spoken about these extrahepatic manifestations in the later part, you might have actually not got the picture. Now I have just highlighted the common ones, and I've also mentioned the rare ones. The rare ones are usually asked in pathology based questions, and nowadays because it's integrated, so he can obviously mix up the two. So I thought that let me mention about these right at the onset. As hepatitis C causes chronic hepatitis, so it is no big deal that this person will end up with liver cirrhosis, and cirrhosis of the liver will also have certain features. Now, those could be in the form of hand signs developing in a patient, or head signs developing in a patient, or skin signs developing in a patient. So let me enumerate regarding certain hand signs that you always see with cirrhosis. You see, one of the very characteristic manifestation that you always read, and even this is taught in literature of alcoholic cirrhosis, is palmar erythema. The palms of the patient would be bloodshot red as compared to normal pink. Then there could be dependence contracture. What I'm teaching you at the moment are features of compensated cirrhosis, because decompensated cirrhosis will obviously result in ascites and portal hypertension, and then the person can vomit blood, that is esophageal varices. But dupuytren's contracture is a feature of compensated cirrhosis. Even when you look at the nails of these patients, you will notice that the nails will be almost white. They would be pale and white. So leukoonychia can be written in the question. Then clubbing. You see, traditionally you read about clubbing with the infective endocarditis of the subacute variety, or with lung diseases. So traditionally clubbing is associated with cardiovascular and lung diseases, but I'm teaching you clubbing even for cirrhosis, which could be due to alcohol or due to hepatitis C, or a combination of the two. Another hand manifestation that I can write here is flapping tremor, that is asterixis, which would however be seen in the later part of the disease. And when this person will decompensate, that is when he will start having abdominal bloating, fullness, and there would be fluid thrill that would be appreciated, shifting dullness that would be associated. Along with this, we will also be able to feel or notice the pitting pedal edema that comes in. There could be caput medusae that will be noticed around the umbilicus of the patient. You know that in caput medusae, the flow of blood is away from the umbilicus. The word is away from the umbilicus. And well, God help this guy if he starts having rupture of the esophageal varices, which will cause hematemesis. And the management of the decompensated part of cirrhosis is mentioned in the subsequent part of the app. The basic message that I've tried to given to you here is that Hep C can actually have a very non-specific complaints initially, where diagnosis may not be made. Most of the cases, the diagnosis is actually made when the person starts developing features of liver cirrhosis. And in some cases, even there could be development of hepatocellular carcinoma. And here again, I would like to address that controversy, that what is the leading virus responsible for hepatocellular carcinoma. In Robbins, it is given as hepatitis C virus, but I want to tell you that in Harrison, when you read the hepatocellular carcinoma chapter in volume 1, you will notice that first he has given hepatitis B. Well, what's the big deal? The big deal is, guys, hepatitis B is more common in I would say the developing countries. In America, because Robbins is given pure American based data, it is hepatitis C that is written, so there's no controversy. All I'm telling is that they're giving data according to the prevalence. You see, in Harrison he has taken on a global scale. You see, hepatitis B is more common than hepatitis C. As a result of it, he's written Bombay, hepatitis Bombay first, and Robbins has taken purely American data, so he's written hepatitis C. And anyway, don't bother about controversies, guys. I mean, controversies will never make or break a career. Controversial questions are never asked, or even if they're asked, that is one odd question which is always a bouncer for everybody. So you really don't need to be bothered about that in Robbins this is given, in Harrison this is given. I agree there would be some discrepancy. We just need to keep an open mind and accept the data first, and then try to analyze what should be the best possible answer. Like in hepatocellular carcinoma, I explained that it is hepatitis Bombay which is given first in Harrison, so that is what I would suggest you to follow. Now, let us look at what would you do for the workup of these patients, what tests would you write, and you need to compare that with hepatitis B. The first test that I'm going to do here is EIA, that is enzyme immunoassay anti-HCV antibody. This is obviously going to be combined with liver function test. Once the test comes out to be positive, it means that person is having hepatitis C infection, and antibodies obviously take time to develop, and because this person might have acquired the infection earlier, so it may be substantial number of years before this person has actually been diagnosed with what was wrong with this person. I also want to tell you that this test can be false positive. This test can be false positive with autoimmune hepatitis. I have discussed autoimmune hepatitis separately, inferiorly in the same section of the liver, so you can go through that, and therefore you cannot call this as the best test. The best test for diagnosis of this condition, or I can say investigation of choice for diagnosis of hepatitis C, would be answered as PCR. I would be doing a PCR HCV RNA, and I will be able to then initiate treatment of the patient. And here I also want to tell you that there is no cutoff value in this case. Like in hepatitis Bombay, we have a cutoff like 2 into 10 to the power 4 or 2 into 10 to the power 3. We determine how many viral copies are present per ml of blood. In this particular case, even if it is one virus, 100 viruses, 1000 viruses, 1 crore viruses per ml of blood, you need to treat all cases, whether it is 1 crore viruses per ml of blood. All patients will definitely require a treatment. So there is no such cutoff, like unlike in hepatitis B, where we define a cutoff that okay, this much viral load along with elevated SGPT. In this particular topic, there's a distinct possibility that SGPT of the patient could be normal, but it could be normal this month. Now the next month it could start rising after 15 days, after 30 days, so you really can't predict. So SGPT normal does not rule out the fact that you're not going to treat. When I was teaching you hepatitis B, I said minimum you should have a doubling of SGPT values, with obviously the hepatitis B virus PCR will be showing elevated counts up to 20,000 viral copies per ml of blood, or 2,000 depending on whether cirrhosis are there or not there. But the point is there is no cutoff which is to be taken in case of hep C. Now we will talk about the treatment domain of these patients. So we will study what will you do for patients of chronic hepatitis C, and the objective is to prevent them from getting converted into a decompensated cirrhosis, then a development of end-stage liver disease, and then even rarely a development of hepatocellular carcinoma. So treatment is to be given in all the cases irrespective of the serological status. Even if a person is HIV positive with hepatitis C, we would still treat the person. The treatment is given genotype wise. One of the common drugs that is used for management of genotype 1, because that's the common one in America, is called as non-structural protein 5A inhibitor, and you all know the name. And in fact, this has been asked in pharmacology in the AIMS exam as well. So your answer would be ledipasvir. However, if he talks about genotype 2, actually there are 6 genotypes. I'm going to talk about the common ones. So usually he will ask you about genotype 1 or genotype 2. And for genotype 2, we will be using sofosbuvir. This is relatively an expensive molecule, sofosbuvir. And along with this, we use ribavirin. Yes, the same ribavirin which we study for in pediatrics for RSV associated bronchiolitis, and ribavirin was even tried in COVID-19 pneumonia, though it did not show any effect. So I just want you to be familiar with the drugs that I mentioned here. And when I was a student at your age, then I had a straightforward answer. There was no discussion as genotype wise. They just used to mention in the book that we will be giving shots of pegylated interferon. As you know, interferon is a immunobooster. It will pump up the immunity. The immunity will kill the virus. So interferon per se is not a directly antiviral drug, but the drugs that I've written superiorly are mainly antiviral drugs that they'll hit the virus directly rather than upgrading the immunity. So when I was a student your age, I used to read about combo of ribavirin with pegylated interferon. So if you attempt MCQs of 2015 and earlier, you will notice that the combination was being discussed, but at the moment it is going to be answered as antivirals as I've highlighted before you, and the objective is to attain a sustained virological response. Lots of MCQs will use this term SVR. It basically means that you are suppressing the viral replication. You are trying to reduce the damage in the hepatocyte. Sustained viral response of more than 90% is obtained with the drugs that I have written here before you. Additional fact which is optional, I mean you don't need to note it down, but I just can say off record is because just recently I got a message from this young lady doctor. She has been a student of mine. She got a prick from a Hep C positive patient. Well, her first query, when she sent me this message, the unfortunate one was that, doctor, is there a post-exposure prophylaxis for hepatitis C? Well, there is none. There is no post-exposure prophylaxis for hepatitis C, unlike for hepatitis B. And then her query was, what are the chances that I could get the disease? You see, with hepatitis B, obviously, and with HIV, the percentages are already discussed. But if it comes to, per se, a figure-based question where he says, what are the chances of transmission with the accidental inoculation or needle stick injury? It could be a suture needle, it could be a hollow hypodermic needle. You're trying to put the cap back on the needle, and a doctor can get a prick. So the chances are close to 3%. What should this doctor now do? I mean, her query was, sir, what should I do? I got a prick today. I'm totally okay. I mean, there's nothing wrong with me. What should I do? So this is what I told her. I said, we will gradually, subsequently evaluate you by doing a PCR HCV RNA. And if you turn out to be positive, within the next 3 months, we are going to treat you as a case of hepatitis C. I want to tell you that in hepatitis B, we definitely have a post-exposure prophylaxis. We can give hepatitis B immunoglobulin in a person, and the protective antibody titer can be checked. But in hepatitis C, even if the protective antibody, the so-called antibody, anti-HCV RNA is still present, this antibody is not protective in the real sense that the fire is still burning. So there is no point of checking antibody titers in hepatitis C. Rather, we need to treat the patient as a case. So, well, she was definitely not very comfortable listening to this. I can understand the discomfort of anybody when you are telling somebody that, well, we will treat you as a case of Hep C. But then unfortunately, you guys need to be very careful, especially when you are suturing an episiotomy wound or you taking sample from a patient. If it's Hep C, then definitely if a person gets a sufficient viral load in the body, he has to be treated as a case of Hep C, provided he turns hepatitis C positive. And not everybody who's going to get the prick will turn positive. It's only, the incidence is only 3%. Unfortunate scenario, the last one that I mentioned. This is just for your general information because protection is important, right? When you guys are going to go for sampling, you should know what are the precautions to be taken. And as I highlighted, I mean, if you just ensure that your index finger is out of the range of when you are suturing an episiotomy wound in dead of the night in the labor room, then, and at the same time for sampling, never recap the needle, you will be on safe grounds. Now I will be comparing the information that I provided to you with that of hepatitis delta virus. The hepatitis delta virus, well, you have to remember from the transmission perspective again is parenterally transmitted, and this is an incomplete virus, guys. So alone it will not be able to cause too much of damage, but when it is gonna be with hepatitis Bombay, hepatitis B virus, then the two friends are gonna cause lot of mayhem, lots of destruction. Then they asked a question which had a PSM basis. They said, how is it possible to eradicate hepatitis delta from India? Well, the best way is that if we will vaccinate whole of our population with hepatitis B vaccine. You see, B and D together cause a problem. If you're gonna vaccinate everybody for B virus, then everybody will be immune against B virus. So alone D won't be able to cause damage because it is relatively an incomplete virus. Small countries like Singapore, or let me say Sri Lanka, they are very, I would say, advanced in a sense that they are better in health indices, and they have attained what I am teaching at the moment because they have done 100% coverage with hepatitis B vaccine. So in those countries the incidence of hepatitis D has dramatically reduced. So we really do not need to invest in some drug, some fancy drug for treatment of hepatitis D. If we just pump up the coverage of hepatitis B vaccine in our community, it is goodbye to this virus. In fact, lots of time when they ask you regarding the transmission part, lots of guys casually answer co-infection, or they might use the word super infection. Please remember, co-infection and super infection are not methods of transmission. They are manifestations of a patient. So let me now explain to you what do I mean by the word co-infection, or what do I mean by the word super infection. And this is again for descriptive purposes, not too much of MCQ importance. What is MCQ as importance, I'll mention towards the end. Listen to my next discussion very carefully for 1 minute. I'm now going to describe you a case of a IV drug user. He is having jaundice, he is having icterus, so that is why he came to me with pain in the right upper quadrant. When I evaluated him, I found that he was surface antigen positive, and IgM class of antibody to the core antigen was present. So my presumptive diagnosis of this guy was that he's suffering from acute hepatitis B. It was only during my routine general physical examination that I noticed this guy with jaundice was having some puncture marks in his cubital fossa. So when I asked him, he agreed that he does IV drugs occasionally. And let me say, this is the status of this guy in the month of February 2021. Now, because IV drugs are expensive, so lots of time these people, to fund their drug habit, might actually be doing small petty crimes like pickpocketing or mobile snatching. So this guy, he might be a college dropout. He actually, he snatches cell phones outside a metro station, etc. And because the crime rate in that particular area was increasing, so the police, the SHO of that area, because he was worried about the increasing crime rate, he asked his constables to round up all these guys. And the beat constables, they know everybody who's a IV drug user, or all the people in the area who do wrong kind of work. Now, all these guys were called in the police station, and the SHO threatened them that either I'm going to beat you up in a lockup or you disappear from this area. I mean, most of the time you see the police does not want to do any kind of action against these IV drug users, etc., because they're habitual offenders. So the police will basically try to, ask them to get out of the particular district. They'll say, okay, go to some XYZ district, do whatever you want to do there, but don't increase the crime rate in my area. So this guy was obviously threatened by the cops, so he moved out. And now let me say he's gone to a different area where he is operating and he's doing the same thing. He's a college dropout, and this chap is still doing mobile snatching, or let me say chain snatching, or petty crimes. Now from that particular district, he's gone to a district far away, 5 kilometers from here, where he is again indulging in high risk behavior, which could be sexual behavior as well as IV drug usage. So he got hepatitis D infection. You can see a person has now acquired, over a span of, let me say, 2 months, two different acute infections. That is one acute hepatitis B, and second infection that he has acquired is acute hepatitis D. So this is what I mean by the word co-infection. In co-infection, both infections might come at the same time or may be separated by a timeline. I repeat that again. Co-infection per se can occur either at the same time or may be separated by a few weeks, and the method of acquiring can also be different. Like first time he maybe got it sexually, second time he got it IV drug usage, or it could be both IV drug usage. But the point is, once the co-infection component comes in, then the recovery part will be relatively delayed, and sometimes there is a distinct possibility that these patients can go into fulminant hepatic failure. Well, there's a slight controversy about it because Harrison and Robbins are always at dispute related to this. But the recent edition of Robbins that came, the 10th edition, and the 20th edition of Harrison, they'll have some differences. But because the 10th edition of Robbins came very recently, there they've highlighted this fact that fulminant hepatic failure can be associated with co-infection. It is not that chronic hepatitis will not occur. It is just percentage wise he is given a higher percentage. So I've highlighted it. The bottom line is that acute hepatitis B recovery would have occurred. When I've taught you hepatitis B, I have very, I would say, vocally highlighted that hepatitis B is a very mild virus. It's media hype that is creating that, okay, hepatitis B is very dangerous, whereas in majority of cases, 90% of cases, recovery will occur. The point is, if you are having a combination of two acute infections, then obviously the damage that can occur in the body of the patient can be relatively more. Let me explain this once again to you in a slightly different fashion. I today have in my OPD a IV drug user. His serological status is hepatitis B surface antigen positive and immunoglobulin G class of antibody to the core antigen also present. So this guy, the way I've written the report, you can understand is suffering from chronic hepatitis B. The timelines will keep the same. We are discussing two different individuals. The first patient was having acute Hep B. This particular patient is having chronic hepatitis B, and when he was threatened by the cops, he go to a different area where he indulged in high risk behavior, and now he has got a acute hepatitis D infection. So you can see the subtle differences that I've tried to incorporate here. Previously I was talking about two acute infections coming in a person over a short period of time, but now I'm talking about a guy with chronic Hep B getting acute hepatitis B, so I'm going to call it a super infection. In this particular case, you see the chronic part will definitely be worsened. He's already having chronicity, no? Already there's a chronic damage occurring in the liver. So this super infection can actually increase the incidence of chronic hepatitis and thereby increasing the chances of cirrhosis and increasing the chances of again a decompensated cirrhosis causing end-stage liver disease. The message that I'm trying to give you here is primarily that there could either be co-infection. So co-infection per se is not a method of transmission. It is a manifestation which could result in fulminant hepatic failure. And if it is a super infection, then when you look at the word super infection, I told that the guy is already having a chronic damage to the liver. So this chronic damage will definitely be exacerbated and chronic hepatitis manifestations can occur in a patient. I also want to draw your attention to the fact that if a question simply says what is the leading cause of fulminant hepatic failure overall, then the leading cause of fulminant hepatic failure overall is hepatitis delta. It is hepatitis delta, 20% incidence is present when it comes to fulminant hepatic failure with pregnancy. I repeat the statement. When it is fulminant hepatic failure with pregnancy, the answer is going to be given as hepatitis E virus. So two statements which are important from exam perspective I want you to remember are: number one cause of fulminant hepatic failure is delta virus, in pregnancy is the E virus, and then you could also be having a fulminant hepatic failure with a co-infection, that is Hep B and Hep D. So two insults together, right? They amplify and therefore they can contribute to more damage in this person. And next we will study regarding what is the treatment to be done. Well, for delta virus per se, you don't need to treat delta virus alone. You need to treat a person who's having a co-infection, that is fulminant hepatic failure. You will treat the fulminant hepatic failure component. Or suppose if somebody is having a chronic Hep D, right? If he's having a chronic Hep D infection, that is a combination with B and D, then we will have to boost up the immunity of this guy. The drug that can be used in this case can either be pegylated interferon, which is relatively expensive, so we can use alpha interferon as well. So I just want you to remember the fact that I have described certain drugs before you which are useful for various viruses. Let's just recall. When I have taught about hepatitis B virus, I have taught you that the drug that can be used for management is tenofovir. If it is not given in options, we will answer this as entecavir. For hepatitis C, as I've highlighted, I'll just bring this slide into focus once again. I spoke a genotype based data, but you can see that because genotype 1 is the common one in America, so the answer would be given as ledipasvir. Then when it comes to hepatitis delta, it's not gonna be able to cause any substantial damage together, but if it's a chronic scenario, then we can boost up the immunity with alpha interferon. Now I'm using this opportunity to introduce another aspect, which is that beta interferon has been discussed for multiple sclerosis. And well, gamma interferon is useful for management of sepsis. So I'm also brushing up your pharmacology along with the standard information. You can just go through this table, and I'm very sure all of you are familiar with this information. It was just a quick brush up that I had requested here. I shall now be explaining to you regarding the manifestations of fulminant hepatic failure and the treatment that we're gonna do. I first want to highlight what is the cutoff for fulminant hepatic failure. Well, in Davidson, the cutoff is given to be 2 weeks, but in most of the textbooks which are related to hepatology, it is given to be cutoff of 8 weeks. Well, let me just explain. The causes of fulminant hepatic failure can vary from toxins to viral hepatitis, Well, overall, if they ask you what is the number one cause of fulminant hepatic failure, then don't answer hepatitis delta or viral hepatitis. It is rather toxins. In majority of cases, some books it's given 40, some books it is given 80%, but it is toxins that are relatively more common than viral hepatitis. And let me just elaborate the toxins. From pediatric domain, it could be paracetamol toxicity. There is a separate lecture on the same, the management perspective in the later part of the app in liver section only. Then let me say you are at a primary health center, you have given ATT to a person. Whenever you prescribe ATT, you should always tell the person to come to you for follow-up. And apart from that, if he tells jaundice, he should actually see you even earlier. You see, from both pharmacological domain, it is important for you to know, and obviously the clinical one, that pyrazinamide is one of the most hepatotoxic antitubercular drugs. So you started pyrazinamide in any person in a primary health center and he starts developing jaundice, you need to discontinue pyrazinamide. It could be antitubercular drugs, it could be, let me say, anesthetic drugs like halothane, or the next example I can talk about is mushroom poisoning, that is Amanita. You see, couple of doctors, they cleared their final year exam and they were fairly happy, excited after clearing this because they are going to be starting internship soon. So these couple of doctors, they went to trekking. Now when they went for trekking, on the way back there was a landslide and they could not obviously come back, and they ran out of food supplies also. So because they're finished with snacks, they ate some wild mushrooms, and when they came back, obviously they were rescued by the forces. When they came back, they suffered from fulminant hepatic failure. I want you to remember that toxins are more important than viral hepatitis. Viral hepatitis aspect I've already explained to you. It is hepatitis delta. In pregnancy, it is hepatitis E virus. Now, once there is an insult, then there could be two things developing in a patient in a 8-week period. Like these young guys, they came back, they ate mushroom, they're not going to have a liver failure immediately. Within the next 2 months, their liver can fail, and what is going to develop in them? Either of the two things. Because liver is a source of clotting factors and the production is gonna be hampered, so either these patients could be having a coagulopathy and a deranged prothrombin time, activated partial thromboplastin time. Liver is also the site for detoxification of ammonia, so they can start developing features of ammonia intoxication, that is encephalopathy. Between the two, I have written the word and or. So I basically want you to remember that whenever there is an insult to the liver, it could be due to toxins, it could be viral hepatitis, it could be drugs. Within a 8-week period, if any of the two informations that are written on the board is developing, it means that we will write on the case file the word fulminant hepatic failure. Let us now see why this person will come to you. I mean, I've already explained the diagnostic criteria, but we just need to make a list of the important clinical features. And one would be obviously that the jaundice of the patient is worsening. I mean, when it any time if the liver will decompensate, I've just written 3 plus in front of jaundice to highlight the severity of it is increasing. But how do I know that this worsening of jaundice is causing a fulminant hepatic failure, or does it represent a fulminant hepatic failure or not? You will be having certain very classical manifestations of encephalopathy. You see, in the exam he has asked what is the earliest manifestation of hepatic encephalopathy, then the answer is not worsening of jaundice, because worsening of jaundice can be seen even in progression of cirrhosis. If I just say a patient is having worsening of cirrhosis versus a patient who's having hepatic encephalopathy, both would be having gradually increasing jaundice. The differentiating feature is that a patient of cirrhosis who is not having an encephalopathy, there would be a normal sensorium. He can at least talk to you normally. But in this particular case, there might be development of psychiatric manifestations. In fact, lots of patients would be having alteration of sleep wave cycle. I want to highlight this once again. If the question says what is the earliest manifestation of hepatic encephalopathy, your answer would be given as alteration of sleep awake cycle. The family members are saying that he tends to sleep the whole day, is awake the whole night, and when you gonna talk to this guy, he will talk as if he's very happy, euphoria. You will also notice that there will be slurring of the voice of this person, like in the casualty. If you have ever talked to an alcoholic patient, a guy under intoxication, you will notice the slurring in the voice. Similarly here, in this particular patient, there would be slurring of voice, and you will ask the family member that is he drunk? He's saying, no, sir, he does not even drink alcohol. He's a teetotaler. He has never consumed alcohol in his life. But following this liver insult, which they may or may not be aware of, this person is having this voice change. Then you need to demonstrate constructional apraxia in this patient. You see, the ammonia intoxication will actually contribute to confusion, and his non-dominant parietal lobe will not be able to function properly. For diagnosis of constructional apraxia, one method is that I can do or perform what is called as a clock phase test. In clock phase test, all I need to do is I can draw a clock like this. I can put markings like 1, 2, 3, 4, 5, 6, right? And I can just put the big needle and the small needle, right? Maybe in different colors also. And I can ask the patient to draw time. Now, a normal person, this is obviously the control. This is what I have drawn. In a patient of construction apraxia, you will notice that he might actually draw the clock like this. But then all the numbers from 1 to 12, all the numbers from 1 to 12 might be jumbled on one side only. And he may not draw the needle, or he might draw only one needle only. He's not getting the orientation of the numbers. Let me explain in one more different fashion. I'm writing on a piece of paper these numbers like 1, 2, 3, 4, 5, 6 randomly on different sides of the paper. If I ask you, doctor, can you join 1 to 2 and 2 to 3? Obviously, you know the numerals, so you can join 1, 2, 3, 4, 5, 6. In this patient, you will notice that he will randomly start joining the numbers. So you stopped him. You said, come on, man, what are you doing? And you see that even in spite of your asking and scolding, he's randomly joining the numbers, which is telling you that his orientation for mathematics is not clear, or orientation for counting is not clear. The test that I've done here is simply called as a number connection test. So I just want you to remember that clock phase test and number connection test can be done by you to identify constructional apraxia manifestations in a patient, which means that the non-dominant parietal lobe is not functioning properly. Next, I'm gonna take out my cell phone and I'm just gonna show my cell phone to this guy. Cell phone is such a common thing in India, even in the, I would say, rural India, even the poorest of the poor people nowadays are having smartphones. So even if you show a routine phone to a person, you're not even asking brand or some feature of a cell phone. You're just saying, what is this object? And this guy just looking at you and then looking at the object, he's appearing, his facial expression is like, a facial expression of yours and mine in an anatomy viva. You study the whole night, you go for anatomy viva, they will give you a bone and they will say, okay, hold the bone in anatomical position or organ in anatomical position and tell me the origin insertion of various muscles. We have studied the whole night, we are not going to remember it. There it's a problem of too much of data, so we are not remembering. But this guy cannot even tell you it is a cell phone. He knows it's a cell phone. In spite of the fact that he knows it is a cell phone, he will not be able to tell you that. So another feature that is coming up is anomic aphasia. You see, in my discussion of stroke, I have talked about the various types of aphasia, especially Wernicke's, conduction, and then the motor aphasia. But meaning of the word anomic aphasia would be difficulty in naming an object. So just get the name right. Difficulty in naming an object, that is anomic aphasia, is a very characteristic feature which is again evaluated in patients of hepatic encephalopathy / metabolic encephalopathy. In fact, lots of time in MCQs, they would just like to mention the term metabolic encephalopathy. What are the various metabolic encephalopathies that you traditionally study? So I can just mention names here. One would be carbon dioxide narcosis that can be seen in status asthmaticus patients. Another can be uremic encephalopathy. The urea levels are spiking since the person has gone into acute kidney injury. And obviously the topic of interest, hepatic encephalopathy, where there would be ammonia intoxication occurring in this guy. The next feature that will develop in this patient is very characteristic, that is called as asterixis, for which you will ask this person to outstretch his hand and you can slightly dorsiflex it, let it go, it will start beating like a wing of a bird. Asterixis or flapping tremor is one of the reliable features that you can use to identify metabolic encephalopathy in a patient. I have today highlighted a couple of manifestations which are beginning with alphabet A, so I can just highlight them. The manifestations which are important from the exam perspective and should be known to you, the earliest manifestation is alteration of sleep wave cycle. Then can be constructional apraxia that can be evaluated by a clock phase test or by a number connection test. Then is anomic aphasia, then is gonna be asterixis. So if you just get these A's right, you would be definitely able to remember the manifestations that will occur due to ammonia intoxication. The bad news is that this person will subsequently deteriorate and will progress into stupor and then a development of a coma. I also want you to remember that this person is having flapping tremors and not fine tremors of the fingers. Fine tremors of the fingers are what you read with conditions like anxiety neurosis. Then endocrinologically speaking, we read this with the Graves' disease, that is thyrotoxicosis, and lastly even pheochromocytoma. This is itself a question that was asked, that all are examples of fine tremor except that is going to be anxiety, grace, pheochromocytoma. In all of them, the catecholamine drive is definitely increased, but flapping tremors are primarily due to a metabolic encephalopathy component. And for asterixes, you need to remember this is a reliable sign. Obviously, the best way to diagnose a metabolic encephalopathy is to testing, like blood ammonia levels, or to evaluate kidney function test, or do a ABG to check for the carbon dioxide narcosis component. But a reliable sign of metabolic encephalopathy should be remembered as asterixis. Now, before I write down the investigations or tests to be done for diagnosis of this condition, I can put up a question to you guys. What is the site of ammonia production in the body? You see, the site of ammonia detoxification is the liver, but where is it produced? Well, it is the intestinal bacteria which are the site for ammonia synthesis, and the detoxification occurs in the liver, where it will combine it with carbon dioxide to produce urea. So urea is produced in the liver and is excreted by the kidney. Why I asked you this question is to sensitize you to the fact that you see, let me say, a patient of liver disease is having coagulopathy, he is having internal GI bleeding. So by red arrows I have shown that this guy is having bleeding inside due to the coagulopathy component. Now, blood is a very good culture media. So therefore, what will happen here is that because it's a very good culture media, the bacterial counts will increase dramatically. And as the bacterial counts will increase, so will be the synthesis of ammonia. And that is the reason why we always study that hepatic encephalopathy can be triggered by GI bleeding. I repeat the fact once again, this guy is having an internal GI bleeding at the moment. The blood is a very good culture media, so the bacterial counts will increase. That means more ammonia production, and as a result of this manifestation, or as a result of this implication, the person will deteriorate. So it is very important to control the bleed. It's very important to control the coagulogram component of this patient, because without it, it's gonna be like I would say a car without a driver. It's bound to crash. With this information inside, we have a look at what are the tests which are important for this patient. Obviously, I'll be doing a liver function test and compare it with the previous reports. So the serum bilirubin is worsening. The SGOT component will be increasing. SGPT will also be increasing. Imagining that this guy is having a hepatocellular jaundice, not obstructive jaundice. So I've shown SAP values to be normal. A very important test that must be done in these patients is coagulogram. I mean, if you are capable of controlling the coagulogram within normal limits, you will definitely ensure that this guy will live. The components of the coagulogram can be bleeding time, prothrombin time, activated partial thromboplastin time. Normal bleeding time is 2 to 9 minutes, prothrombin time is 11 to 16 seconds, and APDT is 30 to 45 seconds, and you know that. Bleeding time is done to test for whether the platelets will function normally or not. Prothrombin time is done to test for whether the extrinsic system of clotting will work properly or not. And APTT is done to test whether intrinsic system of clotting is done properly or not. Please remember the fact that prothrombin time operates on factor 5 and 7, APTT on factor 8. These are some very baseline data that I mentioned before you. And can you recall the shortest half-life clotting factor? I mean, which clotting factor has the shortest half-life, which has the longest half-life? Shortest half-life is of factor 7, which explains to you the fact that why prothrombin time is mostly deranged in all MCQs of liver disease. I repeat the fact again because factor 7 has the shortest half-life. Factor 13 has the longest, but we are studying mainly focusing on the shortest component. Because this is shortest, therefore prothrombin time will be the first one to be deranged. In patients who are suffering from fulminant hepatic failure, in fact, subsequently, all parameters might get deranged. In fact, the report might look like that of a DIC patient. In DIC, all parameters are deranged. I'm saying in initial part of liver disease, it may be only prothrombin time, but after all, then all other clotting factor synthesis will be reduced. So APTT will also be deranged. Later on, portal hypertension might occur, splenomegaly might occur, hypersplenism might occur, and hypersplenism will contribute to thrombocytopenia also. So even bleeding time will increase. So my message is that coagulogram will always be deranged with special emphasis on prothrombin time. If the question says what is the best way to know that your patient has landed up in a hepatic encephalopathy / fulminant hepatic failure, because you need to demonstrate both the things. Either it could be coagulopathy, it could be encephalopathy, or a combination of the two. So to be sure about your diagnosis, you should do blood ammonia levels. Now, this facility may not be available in all government hospitals, because even if you draw a sample, you need to refrigerate it, because it may not be tested today, it might be tested the next day morning. So there's a distinct possibility that this facility either is not available or the sample was not refrigerated properly. So lots of time we might be using EEG to our diagnostic advantage. The EEG finding that you will notice in this patient would be one, triphasic waves. This is itself an MCQ, triphasic waves. Image-based question of triphasic waves are discussed in the previous year paper section, where I've described what I mean by the word triphasic waves, and even in the EEG part. The next point that I want to highlight is delta waves. Normally, delta waves are present when a person is in NREM stage 3, deep sleep, but this particular guy who's progressing towards coma is also having delta waves. So just get these words right. Triphasic waves and delta waves, especially the word triphasic waves is what they love to ask, is a feature that is seen with hepatic encephalopathy. I would also be doing an ultrasound of this patient, because I want to check for the span of the liver, because as the liver will shrink in size, the values of ammonia will definitely begin to rise in this person. Kidney function test should also be done in these patients. Why? Because serum creatinine of this chap will definitely rise. There's a complication called as hepatorenal syndrome. I've shot a separate lecture on hepatorenal in the latter part of the app in the liver section only. So yeah, I definitely want you to remember the test that would be done, and the importance of KFT is mainly to check for evidence of hepatorenal syndrome. At this juncture, another reason why I'm doing a KFT in the patient is because I want to calculate the MELD score of the patient. You see, what I'm trying to do here is I want to know whether I should refer this guy to a higher center for orthoptic liver transplantation right away, or should I tell the relatives that okay, we will first try to manage the case medically, and if he's not going to improve, we are going to refer him subsequently. So we can actually calculate a score called as MELD score, by which we can decide the prognosis of our patient and also decide for referral. The components of MELD score have been very frequently asked in the exam. They are taught in surgery also. There are three of them, that is bilirubin, international normalized ratio / prothrombin time, and serum creatinine. You will notice that prothrombin time is present in almost all the scoring patterns related to the liver. So just get the names right. Bilirubin, INR are anyway components of liver damage. And apart from that, serum creatinine, if it is jacked up, it definitely means that the person is deteriorating. I also want to tell you that higher is the MELD score value, more is the need for orthoptic liver transplantation. In some books, it might be given as 18, some books might be given as 17. The values can vary, but a value of at least 17 or higher indicates a bad prognosis. So you need to ASAP, as soon as possible, register this patient for orthoptic liver transplantation. At this junction, I also want to remind you about another score which we actually use in cirrhosis topic. We call it child pug score. Even that is used as a guide to decide for liver transplantation. So I will just mention the parameters which are important for child pug score. Bilirubin, INR are always going to be there, as I've highlighted, but now there will be some investigations and some terms that begin with alphabet A once again. The first one that I want you to remember here is serum albumin values. They will progressively reduce. As albumin will become lesser, the ascites component will deteriorate in this patient, and as the ammonia component will rise, asterixis will start occurring in this patient. Actually, it is a range 7 to 9, but I'm just putting a value. If it is a value more than 8, then we need to plan the patient to be registered for orthoptic liver transplantation. Even if you don't remember the mathematical values that are wrote here before you, I want you to relate to the fact that we are not going to randomly decide that okay, this patient of fulminant hepatic failure will require medical treatment, this patient will require a orthoptic liver transplantation. Based on the severity of the disease, higher the MELD score, more is the requirement towards liver transplantation. And there's a possibility that today the MELD score might be less than 17, but over the next couple of days his condition might deteriorate. So enlisting or registering for orthoptic liver transplantation, the thresholds is what I have mentioned here, and they might be a little different from what they might teach you in surgery, because different books have different values, and they're not gonna worry about the mathematical value that I've said, because it's a range. Like child pug, when you read about especially stage B, that's basically a range of 7 to 9 as a score. So I have just given an intermediate value of 8 here. Next, I'm going to explain to you what will be the medical treatment of a patient of fulminant hepatic failure who's not having a requirement of a liver transplantation at the moment, or let me say, even if we plan a liver transplantation, we need to still medically manage him before we shift him to a higher center. So let's study about the drugs which are going to be used by you to stabilize this guy. The first of one that you will be using will be given with the help of a NG tube, that is lactulose. This is a ammonia binder and at the same time also contributes to diarrhea. Well, what is the advantage of causing diarrhea in this patient? It's going to be messy, but the point is when he will have diarrhea, then the gut bacteria load will be reduced in the body of this person. That is again important. I repeat the statement once again. Bacteria are the source of ammonia production. If I reduce the fecal matter in the gut, the more the colon is clean, lesser will be the ammonia production. So lactulose will be used and should be answered as the drug of choice for this condition. You see, drug of choice per se is a very myopic view on any topic per se. I mean, lactulose is used for this condition. It gives a good response. So that is why it's taken as drug of choice. But it's obviously not going to cure the patient. I will also be starting these patients on rifaximin, which is a bacteriostatic antibiotic. And you have studied about this in management of traveler's diarrhea. Or another topical antibiotic that I can use here is neomycin. The main reason why I'm giving these bacteriostatic antibiotics to the patient with help of a nasogastric tube is to decrease the multiplication of bacteria in the gut. I will also be asking my nurse to give enema to my patient, and she might be asking me, sir, the patient is in coma, he's not eaten for 2 days, and you are asking me to give enema twice a day. Why? I mean, he's not eating, there would be no fecal matter. I said, I just want to keep the colon as clean as possible to reduce the bacterial load and thereby decrease the amount of ammonia level in the body of this guy. The next thing that I'm going to use in this patient is called as Lola. This is amino acid infusion. Amino acid infusions are used in these patients. Why? Because they will help in clearance of ammonia. This full form will definitely be studied by you even in other subjects also, that is L-ornithine and L-aspartate. When I'm gonna use this Lola infusion, what is it gonna do? It will bind to ammonia and help in its excretion. Combination of ammonia with Lola results in production of glutamine. And now the good news is that this glutamine will be excreted via the kidney. You see, I'm just playing with pharmacology in this case. When I say I am playing with pharmacology, I basically means that if a product is not getting kicked out by the liver, I'm making the kidney do its job. The brand name for Lola would be Hepamers. I can just mention the name here. Lots of time you would have seen this infusion being given in very sick patients with a degenerated liver process. The next thing might look a little surprising to you, but we have this technology available right now. You see, earlier we were only having dialysis whenever a person is having renal failure, but I'm gonna teach you dialysis for liver failure. Well, this is a very, I would say, new technology that has come up that is called as MARS. The full form of MARS would be Molecular Absorbent Recirculating System. It simply means that we now have the capacity to even remove ammonia from the body. So for a non-medico, I will say that we are gonna do a dialysis. And if it's a relative who's a little educated, they might say, sir, we have read about dialysis for kidney failure. You were telling us dialysis for liver failure. So yes, this is definitely available. You see, you need to wait and watch in this case and ensure that the standard care of a comatose patient is taken. Care of the bowel, care of the back of the patient, care of the bladder of the patient is of paramount importance, because let me say, God forbid, if he is not lying on a air mattress, or let me say a mattress which is comfortable for the patient, there might be a bed sore. That reveals failure of the entire medical unit, because if your patient who's critically sick and comatose is developing a bed sore or a decubitus ulcer, and tomorrow if that gets infected, there is a sepsis, your all hard work has gone waste. So here the nursing care also adopts a very important function. And well, I can say that if you are gonna treat this guy conservatively, it is not that he's not gonna recover. Yes, I've personally seen cases recovering with only conservative management, patients waking out of coma. Why? How is that possible? You see, liver is the only organ in the body where some percentage is destroyed, but the remaining cells can take over the function of the damaged cells. If brain is damaged, it's not that if left part of the brain is damaged, then right part of the brain will take over the function of the left. If left ventricle is damaged in anterior wall MI, it is not that the right ventricle will take over the function of the left. I mean, in any organ damage, the remaining cells don't take over the function of the damaged cells, but liver is one such beautiful organ of human body where the remaining cells will take the load of the ones that have been destroyed. In fact, just to make you sensitized to this information, I want to tell you that up to 70% of liver, like suppose if I am a donor for a family member of mine who's requiring a liver transplantation, then up to 70% liver can be removed from a donor. And when you tell this to a patient, he might actually, who's a donor, he might actually ask you, sir, you're going to remove 70% of my liver. How will I survive? I mean, the other person will live actually. How will I survive? You have to explain to this guy that the remaining 30% can take over the function of the removed 70%, and you will definitely be able to lead a healthy life. Like for example, a father is donating liver to his two children. Those children had liver damage due to whatsoever be the reason, and now he's donating liver. So yeah, we can donate a part of the liver to his child or children, and the children will also be fine and the father will also be fine. Orthoptic liver transplantation is definitely the need of the hour based on the MELD score of the patient. Whenever you're gonna tell the relatives that we are gonna plan a liver transplantation, they're definitely gonna ask you, are you doing matching? Because in kidney transplantation, we always are very particular about the matching component. But I want you to remember that for liver transplantation per se, listen to my words very carefully, HLA matching is not mandatory. I repeat the statement once again, HLA matching is not mandatory whenever you are planning a orthoptic liver transplantation in a patient. In fact, conditions where HLA matching is not mandatory is for corneal transplantation, then for cardiac transplantation, and right now the orthoptic liver transplantation aspect. So I have just tried to highlight that we have good immunosuppressive drugs, so no problem even if we do not do a matching. Towards the end of this discussion, I also want to bring to your notice what I have discussed in some other topics. One is when you will listen to alcoholic liver disease, I have talked about discriminant function or discriminant score. This score is basically used to decide whether you need to treat a guy of alcoholic hepatitis. This is itself a question because lots of time they ask MELD score. They can ask you discriminant score also. Why are you using MELD score? That is to decide for need for liver transplantation. In discriminant score, you are evaluating an alcoholic hepatitis patient. Does he need treatment or not? I can put up a question to you guys here. Can you tell me the drug of choice for alcoholic hepatitis? Though it is given subsequently in the app, question to you guys, pharmacology. Can you tell me what is the best treatment for alcoholic hepatitis? I'm not asking you alcohol de-addiction. I'm not asking you about acamprosate and naltrexone. I'm not talking about disulfiram. I am talking about drug of choice for alcoholic hepatitis, that is steroids. We are going to be using prednisolone. Otherwise, this person will progress towards alcoholic cirrhosis. The components which are going to be present here are serum bilirubin and international normalized ratio. No prizes for guessing that. I have already taught you that serum bilirubin and INR are integral components of every liver scoring. Similarly, you need to remember another index or a score that is used for patients of Wilson disease. That would be copper toxicity. The score or the index is called as Nazar's index. Let's look at the parameters which would be present in this case as well. Nazar's index is primarily deciding why do you do it. Nazar's index is done to evaluate the need for liver transplantation, which would be in a case of Wilson disease. The standard parameters will still be very much there. Even serum bilirubin, INR will still be present in these patients with liver enzymes. But the bottom line is, I mean, serum bilirubin, INR anyway components, lots of time they might simply ask you these questions. Discriminant function is used for, Nazar's index is used for, so you just need to get the information right. And when it comes to the treatment of patients of fulminant hepatic failure, it will depend on the MELD score of a person. Medical treatment is anyway gonna be provided to all the patients. Like they can ask you mechanism of action of LOLA, which I said is gonna convert ammonia into glutamine, and that's gonna be excreted by the kidney. The newer method of liver dialysis, MARS, can also be asked to you. So if you just go through this data, I think you will be able to score questions related to hepatitis B, D, and then subsequently the fulminant hepatic failure component. There will always be some disparities, like I've highlighted. I know I have said a certain controversial issues here. I'll name them too so that you can just remember them. One, I've talked talked about hepatitis C, the commonest route of transmission for that is not blood transfusion, it is IV drug user. Lots of guys, they are not able to digest that, and they say, no sir, it's blood transfusion given. Yes, in older times it was blood transfusion. Then for hepatocellular carcinoma, again the disparity, Harrison versus Robbins came up. And another aspect that I've highlighted was that when it comes to transfusion associated hepatitis, it's going to be hepatitis B which is responsible, and the cutoff that is used for hepatic encephalopathy is going to be answered as 8 weeks. In fact, another term I can add to this is subfulminant sometimes, no? So as I told you, fulminant is going to be 8 weeks. If he says the word subfulminant hepatic failure, then you will say it is 8 to 26 weeks. There is definitely some disparity in the values that I've said. I acknowledge that. If they have not been, these disparities have not been sorted out for such a long time, and even if they're present today, they won't be sorted out in future. So don't bother about them. I mean, as I said, uh, controversies never make or break a career. They just make you waste your time. So just try to focus on the routine information that you need to remember for the topics. Thank you so much for hearing me out, guys. Keep hammering, keep learning new facts on a daily basis, and keep an open mind to the new information. Try to jot down the data on small chits and try to stick them on a wall, because the wall technique, as you know, is always going to work. I mean, you have to put, whatever is your weak topic, just put your hand on a heart and say, okay, this is my weak topic, jot it down. Right, then start doing the micro topics of that particular topic, and gradually you will see your knowledge base expanding. Thank you so much for hearing me out.